Hey everyone, Dr. Kuniak with a video lecture this week. So what I had talked about last week was that I wanted to kind of broach the topic of suicidal assessment in this video lecture, and then that'll give us the opportunity to just get into a conversation about it in the next class. I'm not going to hit everything. I've tried to make kind of a list to keep myself organized, but at the same time, at the risk of making this a really long video lecture, which is not what I want to accomplish. Um, I'm going to try to hit all the high notes and kind of start the conversation the way I wanted to. Recognize that first off, if you have already like in your jobs or in aspects of your career, you've already done some assessment for suicidal ideation. That's very valid, and I want to make sure that you speak to that in our live class and feel welcome to speak to it. My experiences with suicidal assessment are going to be different than yours. Some of it depends on um kind of the arena where you're doing this. Like when I did suicidal assessments as part of my family-based work, it looked very different than when I did this for drug and alcohol counseling when I worked in an office, and it's looked even more different when I've done it in private practice. My wife, who has done a lot of suicidal assessments in her career, worked as a supervisor for a crisis network, a county crisis program. And the work that she's much better at having this conversation than I am. She's done a lot of work with the counties and with the state government, related to laws and regulations around this particular topic. But her work with it has been different than the work that I do with it. So, everybody's experiences are valid. I don't think there's a one right way to do this. I just think that the important thing is that you do it, that it's uncomfortable for many folks, especially the first few times that you have to ask someone, are you at risk for harming yourself or killing yourself? And, I think that it creates a lot of anxiety around what that answer is going to be. Know that just because the client tells you, no, I'm not at risk, doesn't mean that they aren't. And really what you're assessing is right now, because there have been times when a counselor does a really thorough suicide assessment. They do not identify any sort of imminent risk, but then the client leaves and they kill themselves. Did the client lie? Possibly. Did the counselor do anything wrong? Maybe, maybe not. What's most likely is the client wasn't suicidal in that moment, but then was later. Or they lied about it. They were feeling suicidal, but they had a plan in place and they didn't want that to be infringed upon. We can all only do so much, and I don't want to minimize this, this conversation or this part of our jobs. But at the end of the day, you can only assess so many things. And if somebody really wants to lie to you or really wants to accomplish this, they will likely find a way to do it. And that's very unfortunate. And I don't want to belabor the point. It's awful. And yet we can still do the best that we can and be wrong, but we want to make sure that we do the best we can. So let's talk about this a little bit. How do you assess for suicide? There's a number of assessment tools out there. The Columbia is one that's very popular right now. The Columbia's CSSRS, if I'm remembering that correctly, the acronym, Columbia Safety and Suicide Rating Scale, something like that. I don't always remember the acronyms really well. We use that in our assessment course, which is something that I teach. And so if you're in my class, we'll play around with it, like you'll practice using it. But you don't have to have a formal assessment to assess for suicidal ideation. You can simply ask a client, I always suggest starting small and working your way up. So, how, are you at risk for, I was just at a doctor's appointment not that long ago, about a week ago, and they were asking these same sort of questions. So it's stuff like, are you feeling depressed? Do you feel sad more of the time than not? Do you have any interest in or a lack of interest in pleasurable activities? And then they'll ask, like, do you ever think about not waking up in the morning? Or do you think about what it would be like for any of this sadness to end? And if they say yes to any of that, it's, well, have you considered harming yourself in any sort of way, or have you considered taking your own life? Ask it directly. Don't beat around the bush. The other thing that I would suggest, and I actually heard a professional do this very recently, is don't minimize it and say things like, you aren't thinking about killing yourself, are you? Because that's really leading the client to say, oh, no, I'm not. It's kind of like when you say to someone, like, how are you doing today? Our knee jerk reaction is to always say, oh, good, even if it's not. So if somebody says, you aren't thinking of doing this, our knee jerk reaction is going to be no, and then it's very difficult for the person to kind of come up around that and say, well, actually, you know so don't invite that. Just say, you know I want to make sure that you're safe. Are you thinking about harming yourself? Are you thinking about killing yourself? And if they say no to that, that's okay. And you can always kind of leave the door open and say, I want you to know that this is a safe place to talk about that stuff. Your safety is the most important thing to me. But I don't want you to feel uncomfortable talking about it, because we all have bad days, and we all have times where we wish that things would be different. So it's okay to have a conversation with me about these things if that should come up with you. You can also say it doesn't immediately mean that you're going to have to go to a hospital, but I hedge on things like that because it might. And that's something we'll talk about in just a moment. I think that you have to wait until you know the client a little bit better for, it's not promising something, but it's alluding to something. It can be leading. Look for warning signs with the client. So even if you ask that, and I do recommend asking it in your intake assessment, it's part of it's part of those forms that I shared with you. It's something that you can just ask to start off. You can ask if the person is feeling depressed, or at risk for harming themselves, or at risk for killing themselves. And then, even if they say no, then it's something that you can kind of check in on periodically. But watch for warning signs. So if a client says, I don't, some days I wish I just wouldn't wake up in the morning, that's worth a conversation. Maybe it just means that they are really exhausted and that they're really bothered by, their life is feeling like Groundhog's Day. Everything is always the same. And, it's frustrating and it's difficult and they're not getting the help that they need, but they really wouldn't actually take their life. Maybe that's the case, but it's worth having the conversation and saying, like, I understand that there have been days where I wish that my life was completely different when I woke up in the morning. But I'm kind of curious, using that kind of language, are you at risk for harming yourself? Do I have to be concerned about your safety in any way? If a client has been depressed and suddenly feels better, that can be a cause for concern. And I'll talk about that in just a moment. If you notice on like pharmaceutical ads and stuff like that, antidepressants and anti-anxiety medications, because the two kind of work in similar areas, will sometimes say that there is a risk for suicidal ideation or a risk for suicide. And the reason for that is the same as what I just talked about. When people suddenly feel better, so if you think about depression as like a an inverted slope, when people are really at the depth of their depression, they're not doing anything. They have a hard time getting out of bed. They don't have any interest in pleasurable activities. They're not considering alternatives. Once people start to feel a little bit better, there's the opportunity to consider alternatives. And so they may have no interest in killing themselves when they are extremely depressed. But as their mind starts to clear, they may start to consider, I don't want to get there again. So what do I need to do to prevent that from happening? The other thing that might happen is they might realize somewhere in that slope, if I took my life, I wouldn't have to feel this way anymore, which will also make them feel better. It's a relief, if that makes sense. So watch for those sudden changes in mood. A lot of times I think it's easy to feel like, oh, okay, they're out of this, when it really might be a significant warning sign. Another thing that you want to watch for is giving away things of importance. I have had clients come in and say, like, this is my prized record collection or something like that. You've been really helpful to me. I really want you to have it. That's a concern. They're starting to put things that have importance to them, they're starting to will them off to other people so that they're not just left. It's more likely that it's going to come up with family members than that they're going to just give something to you, but it might come up in conversation. I'm going to give you a quick example of another one. If they're looking to find a way to care for their pets for a period of time, that's a cause for concern. This actually came up in an agency where I was supervising. It was not a client that I was working with directly, but I was supervising peer support staff. They were peer support staff or paraprofessionals. They don't necessarily have a degree. They're more employed because of their lived experience with recovering from mental health or substance abuse needs. And so they are trained. Peer support staff are indeed trained, and they're effective at their jobs. I just want to differentiate. That's why we call them that, as opposed to a counselor or a therapist or something like that. So one of our staff was going and working with a client who was relatively depressed. Suicidal ideation had not come up, to my knowledge, in any of their assessments. But they were struggling with some depression, and so at one point, the client said that they were going to be gone for the weekend. They didn't really disclose where. They wanted to know if the peer support staff would watch their cats for them. And it's very easy to see in hindsight that that was a warning sign. At the same time, though, because there were no previous, you know, identifiable risk areas, and because that was not something that this peer support staff had ever even considered, they said they'd be willing to, pop in and, because it's an in-home counseling modality and boundaries get crossed a little bit. Not great, but it happens. um, they did say that they would check in on their cats, and the person did end up taking their life. And so that became, it became a huge concern for the agency. As far as like, we had to go through additional trainings. There was obviously, concern with the loss of the client in general. We had to do kind of a full assessment of like, what did we miss? We decided we didn't really miss anything. But this still happens. So we went through a bunch of trainings around suicide risk and what you want to watch out for and all that. The peer support staff member was obviously significantly affected by this. They had to take some time off. We had to, we found them support as far as that went. But so, when people start to put their affairs in order, as it were, that can be another sign of risk. So my next point is, and I've already kind of touched on this, ask directly. Don't mince words. Don't say you aren't thinking about taking your own life, are you? Don't say, an example of this is actually my dad, who was a medical professional, did not assess for suicide risk. That wasn't part of his job. But he had a very hard time saying things like death or dying, or it was just part of his own anxiety process. It can be very powerful to use this language with people when you take the assessment class and we go over the suicidal assessment. That is often it's not every time, but it's often a piece of feedback that students give, is that they didn't realize how difficult it would be to say these things out loud. And that's why we do it. That's why we practice with it. There's also this fear that if you say it, you'll put it in the client's head, that they may be talking about not waking up in the morning. But if you ask, are you thinking about killing yourself, somewhere inside they'll say, oh no, I hadn't thought about that, but now I do. It doesn't work that way. You're not going to put the client at risk for talking about this. If they were going to consider suicide before, they will, if they were going to consider suicide now, they would have before. It's not your fault for bringing it up. In fact, you can open up the door and it can be a relief for the client that they can now talk about this, and you can help them with this. I want to point out that a lot of times we get very referral happy with these cases. As soon as we start to hear that there's suicidal ideation, it is normal for a counselor to want to put the client in the hospital. Know that hospital stays are very brief. They're not meant to actually, for lack of better words, cure the suicidal ideation. The client is meant to go into the hospital to have 24 hours supervision to preserve their life for 24, 48, 72 hours, but they'll be released. And also, if the client tells you they're at risk for suicide, but then goes into the hospital and is not displaying signs of imminent risk, they may not go inpatient. They may not be sent to the hospital. Also know, though, that a hospital stay can be traumatizing for a client who doesn't really need it. Like if they need to go in for their own safety, absolutely, they should do that, and you should help them with that. But if they could better manage those symptoms elsewhere, which is part of the assessment process, a hospital stay can be very traumatizing for a client. They will be brought in, they'll have their clothing taken from them and all of their their physical any items that they have on their person taken away. They'll be put in a gown, they'll be put into a padded room or an isolated room. If they go up onto the inpatient wing, many of those folks on the inpatient wing are actively suicidal, potentially homicidal, potentially, in like florid levels of psychosis. Maybe not, but maybe. And so a lot of feedback we've gotten over the years from clients, and I say we, like counselors in general, this is something that gets talked about in our continuing ed trainings. A lot of feedback from clients has been that the hospitalization process was more traumatizing than having the conversation about taking their own life. So, if they need it, absolutely. We should not worry about those other aspects. But if we're trying to assess and we're kind of on the fence about it, if you recall, I think I shared about a client of mine who that was one of the first conversations they had with me was, their baseline was sometimes being suicidal. They were managing it, but that was always where they were at. So they didn't want to be hospitalized every time they brought up suicidal ideation with me. They were trying to actively work on it. And that was a client who could very easily advocate for themselves, and they did very well. Not all clients are going to be there. But that's part of the assessment process, is deciding, is there imminent risk, or can we put other safety protocols in place to manage this outside of a hospital setting? Maybe, maybe not. And it's not inappropriate to try to get a second opinion. That's why there are county crisis lines. That's why, you can take someone to or send someone to the hospital to be assessed without the intention of 302ing them and involuntarily committing them. An involuntary commitment, a form 302, comes with some additional, and it's called different things in other places. I used to know some of the terms for other states, but in Pennsylvania, it's a 302. I think it's a 201 if it's a voluntary hospitalization. So the client can voluntarily put themselves in for their own safety. But if they're not wanting to go in and you feel like they absolutely must, it's called a 302. That's only going to keep them for 72 hours. And it also comes with other things like they won't be able to purchase firearms afterwards in many cases, and this became a concern for some of my clients. They won't be able to get hunting licenses or things of that sort. um, you know so as opposed to a voluntary commitment, where I believe that again, don't quote me on this. I'm not as practiced with the state regulations around these things, but it won't impact their life going forward in the same way. So sometimes that is a way to encourage a client to get themselves checked out. At the same time, again, it may not meet the criteria for imminent risk. Like if they're not actively suicidal, depending on the physician that you get to sign off on the 302, they may or may not put them inpatient. You may feel like they absolutely need to, but the physician may not think so. The other thing happens too, where you want them to just be assessed, but the physician says, I'm not risking my medical license, they're going in. So, once you move it to the hospital, you lose control of the situation. I can't emphasize this enough. Maybe that's what needs to happen, but maybe it's not. So you need to think about this stuff, because I know it can be very easy to kind of knee jerk. I hear suicide, I hospitalize them. I think it's appropriate to always ask a little bit more. I talked about this in one of our previous classes. So just because you hear, you say, are you at risk for killing yourself? And they say no, ask some other questions. Do they have a potential plan that they would put in place? Have they ever thought about how they might do it if they would? Maybe they don't feel suicidal now, but they've considered it in the past or in the recent past. Ask a little bit more to get a feel for what's going on. It's not just are you doing this? Yes, this happens. It's not prescriptive. We need to get a feel for what's happening. I also put, because I've had this come up as a question from students, they'll say well, what happens if I assess suicidal ideation? I want them to go inpatient. They don't want to, and they say they're going to leave my office. What do I do if they walk out? Because we really don't restrain clients, unless you work in a facility where that's part of you being trained to do those sort of things. I would never restrain my client in private practice unless I was defending myself. That's never come up as an issue, but I'll just say it just in case. But what do you do? Well, you can call the police and say, I have, I'm, such and such counselor. I was working with a client. Like, it's breaching confidentiality, but we breach confidentiality for issues of safety like this, and they'll say stuff like, what do you do if if they leave the office and are walking down the street or whatever? And I've said, like, I've had many a professor who said, and I will echo this, this has always been my plan. It's never happened, but it's always been my plan. You go as far as, they've walked out of my office, they've made a left down on such and such street, they're heading in this direction. No, I don't know their car or their license plate number, but this is their address. That's why it's also helpful when you intake a client, because you never know what's going to come down the pike, to get as much, even if it's online, like even if you're doing a tele session, get their address, get consent for two emergency contacts, um, have a conversation about where they're very, like, where they would go if they needed these things, so that they know, and so you have record of it in case you would need to send them somewhere. What's the local hospital that they would prefer to go to if you discovered some sort of an emergency going on? You can look up things like, if they tell you their address is in, I live in Westmoreland County, but if they said they were in Cumberland County, for example, out towards Harrisburg, um, you can look up the county crisis lines, um, just to have another resource to you, and just put that in their chart, put that as a notation on their intake form, something like that, because you never know when you'll need it. I don't necessarily think you need to get things like license plate numbers and stuff like that, but you could. Not something that I usually get. I just start with address, locality. I make some notations about that, and I get a couple emergency contacts. In telecounseling, it would not be inappropriate. Like, I've had conversations with other family members as part of my tele mental health work with a client. Like, I'll want them to introduce me to their parents or their spouse or something like that, just so they know who I am and I know who they are, should I need to call them. Again, it doesn't happen a lot, but if I needed it, it would be a lot easier to have a conversation with someone that, that knew who I was and what I was calling about. So I think that's enough for starters. I'm sure I've missed things, and again, maybe my experiences or perspectives are different than yours. I look forward to having a conversation about all of that, but I just wanted to make sure I got some of my thoughts out there. So let's talk next time. Have a great rest of the week.